I'm going to go ahead and get started. My name is Bob Segi. I'm the co-director of the community stakeholder engagement component of the Tufts CTSI. And on behalf of myself and our partners at Harvard Catalyst, at the UMass Center for Clinical and Translational Science, and at the BU Clinical Translational Science Institute, I want to welcome everyone to this is our first in a series of research community forum. These arose because all of our centers have a component like ours that focuses on engagement with the communities to make sure that the research that we produce in Massachusetts is relevant to the needs of our community. And the community members have an opportunity to engage in the research in multiple different dimensions. One thing we've heard consistently across all four CTSIs is that individuals in our communities and on our community advisory boards are interested in knowing about the research that goes on within our campuses. And I just want to say that this is really an extraordinary time, an extraordinarily inspiring time. Massachusetts has a huge depth of understanding in biomedical research and in clinical research. I don't know if anyone else has four CTSIs in such close proximity to each other. And each of us are a service organization that provides services to multiple research labs. During this pandemic, much clinical research has been shut down. For example, we're no longer doing research with healthy volunteers. Some research that benefits patients is still continuing, but many of our scientists and investigators have turned from their own academic interests to research that focuses on the urgent needs that we all have to address the challenges of coronavirus. So over the course of the next few weeks, you'll be hearing from a scientist at each institution. And I want to make clear that there are many more, that the purpose of this is to allow a discussion and a dialogue with scientists who happen to work at our institutions. As I'm sure you'll be hearing, across all four institutions, there's an enormous amount of research, and we certainly don't want to represent, for example, the Tufts is the only institution in New England that does modeling, and certainly, as you'll see in the weeks to come, we've just tried to choose exemplary researchers who have an interest in talking with the public to make this whole process more transparent. The way the day is going to flow, next slide, please. The way the afternoon is going to flow, if I got this right, is that I'm going to spend just a little time introducing our speaker, and then most of the time will be spent by Dr. Cohen, who will be talking about modeling the COVID epidemic in real time. And then there'll be plenty of time, about 20 minutes at the end, for a discussion. The way we'd like to manage the discussion, since there are now over 100 participants, is to ask everyone to enter their questions in a chat box. And I and Marguerite Fenwood from our CTSI will be monitoring the chat box. And when Josh has finished his presentation, we will read questions from the chat box to you. We will be saving the chat box, and we may have an opportunity to send information out if there are questions that we don't get a chance to answer, or Josh doesn't. So in introducing Josh, he's the Deputy Director of the, what's the name of your center?
Oh, I'll say it because it's long. And I've had lots of years to practice. Center for the Evaluation of Value and Risk in Health.
There you go. That's what he's the Deputy Director of. And a lot of their work is done on comparative effectiveness, deciding which treatments or which approaches make the most sense and have the highest value for us. And he's an economist by training, and he and his colleagues have been enormously influential in a lot of the work that goes on both at Tufts and around the country on figuring out how to provide the most effective healthcare at the lowest relative cost for us. And it's been a pleasure, Josh and I, back in the day, if you can remember all the way back to the beginning of March, we used to work around the corner from each other and had a chance to chat in the hallways. But seriously, I think that what he's been doing for the hospital is a perfect example of how our research teams have moved from their academic interests to what's required now to support ourselves and our communities. And with that, I'd like to turn it over to Josh. And please remember, as questions come up, please type them in the chat box, and we'll save them for after Josh's formal presentation. So Dr. Cohen, please go ahead.
Thank you very much, Bob. And I'm going to take the screen. Oh, no, I don't have control of it yet. Oh, there we go. All right. Okay, I should be able to see my slides now. My cover slide, I assume, is visible.
Yep.
So, all right, great. That was the scariest part of the whole presentation for me. You know, I guess what I want, what I'm hoping that people get is, you know, in the morning I turn on the radio, I hear, well, you know, Governor Baker's telling us, you know, we're in the surge, we're going to be in the surge until this date or whatever. How do they know that? You know, where does that come from? Of course, they don't really know that. And that's another thing I hope to convey to you is there are limits to what we know. But I think it's really useful to understand where these kinds of conclusions or statements come from, you know, because it concerns all of us. And we should understand what the limitations are, where it comes from. You know, I mean, that gives us all power because, you know, they're deciding on our behalf, but, you know, it's good for us to know. You know, the other thing I'll say is actually, I happen to be the person speaking today, but I've been working with a bunch of scientists. I'll mention them as I go through my talk. But this really is a team effort. And I would say actually my job has been to sort of pull it together, not really have the great thoughts myself. So you'll sort of see, and some of it was quite serendipitous, you know, how these collaborations developed. So with that, let's see here. Let's see, why is this not going forward? Yeah, there we go. Just had to hit the button a little harder. All right, this is me when I get my hair cut. And this is Tufts Medical Center. And you know, when the whole epidemic was really upon us at the beginning of March, I and others were approached by the hospital leadership and asked, you know, like, okay, you guys are good at analysis. We could really use some analysis now because we, as this epidemic gets going, it would really be helpful for us to understand what sort of demands are going to be placed on utilization in the hospital. And it's been amazing how the hospital has converted space and developed more ICU space and so on. But to know what, or to understand, have some sort of handle on what might be coming in the door and where it's going to be placing the greatest demands on the resources that the hospital has, that's a big deal. You know, because you got to be able to plan. And so, you know, we set out with the following task. And the task was to be able to say, all right, you know, how many patients, you know, within the next week or two are going to be on the general ward in the hospital. You know, those are the lower level care beds. How many are going to be in the ICU? And how many are going to be in the ICU and need mechanical ventilator assistance? So that was the general question that we were asked. And so as I said, I was one of the people asked to do this. I am not a doctor, but I was put on a team with some real clinicians who actually know what's going on. A fellow named Dr. David Kent and Dr. John Wong. And so the three of us primarily worked together to understand, you know, how to break this problem down. And so we came up with the following general approach. The idea was to break it really into two problems and to say, well, what we need to focus on first is to understand who's going to come in the door. You know, that's the first problem. And, it would be really good to be able to say exactly who's going to come in the door at Tufts Medical Center, but that's a little complicated because it's a function of, well, exactly where's the hospital located and what's going on in our neighborhood. And what about our sister institutions, which, we're part of a group called Wellforce, and there are other hospitals in that group. So we might get transfers from those hospitals. That level of granularity is very hard to understand before it actually happens. But what we figured we could do is we could say, look, we can kind of model or think about what is going to happen in the state of Massachusetts overall. What's the general load of hospital admissions going to be throughout the state? And that sets a backdrop. And based on that, we can start thinking about specific plausible scenarios that we might see in our hospital. So for example, if we see that, well, today, let's just take today, Thursday, April 23rd, we're getting 5 patients in per day generally over the last several days. And our model says that actually the number of admissions in Massachusetts is going to increase. Well, then a plausible scenario might be to say, well, let's suppose that the number is going to increase to 8 patients per day over the next week or something like that. But you get the general idea. You can come up with plausible scenarios. So that's the first problem. The second problem is, all right, well, once they come in the door, what's going to happen to them? Well, the first thing that happens to them after you test them and figure out, do they test positive for COVID-19? They will end up on the general ward if they test positive. And some of them, hopefully a lot of them will recover from there and they will be discharged. Or if they progress to a more severe level of disease, they might be moved to the ICU. Some of those people will recover at that point and be discharged. And unfortunately, some people will not recover at that point. They'll go on to be put on mechanical ventilation. And at that point, some people, unfortunately, as we know, are going to die. Some people are going to recover. Now, this part of the problem, what are you going to do about that? How do you do that? Well, what you do is you set up a computer simulation where you have hypothetical people in a computer and they have some of the properties of real people. And you have to sit and think about, well, what are those properties going to be? Well, is what proportion of people who are on the general ward are going to recover? What proportion are going to move on to receive care in the ICU? If they end up in the ICU, how long are they going to be there? Well, maybe 10% of the people will be there for 4 days and another 20% will be there for 6 days. You have to come up with assumptions like this. And where do those come from? Well, you try and read articles. A lot of articles have been coming out from the experience of various medical systems from all over the world where they describe some of this information. Sometimes we just talk to doctors in the hospital. And that's why it's great to be able to work with David Kent and John Wong, because they're talking to those doctors. And then the final thing you do is you put your assumptions into the model and you see what the model predicts. And if it's predicting something that looks like what you're seeing, then you're like, well, at least those assumptions are plausible. And if it's predicting something weird, then you're like, something's wrong here, and you dig deeper. Now, the other thing I'll mention is our team's not complete with just me, John Wong, and David Kent. We were put in touch with a professor of computer science over on the Medford campus, a fellow named Michael Hughes. And he has 3 students who were interested in helping us out on this project. And after some conversation, I drew a picture, a little more detailed than what I've got on this slide, but I drew a picture of the model. I think I gave it to them on a Friday, and by Monday morning, they had a working model, which is about, I don't know, 6 months faster than I would have had the model done if I'd even gotten it right. So this collaboration has been really great. And Michael Hughes has been a tremendous help to us. We've also gotten help from research assistants and so on to look up this information. A woman named Ginny Park on David Kent's team has helped us. So it's really been a team collaboration. So anyway, those are the 2 parts of the problem that we've been working on. For this talk, I'm going to focus on the first part. How do we figure out who's going to be walking in or how many people are going to be walking in the door? And what we decided we'd do first is we would start with some of the models that are actually already out there. And some of you may have heard of something called the IHME, or University of Washington model. It's actually been mentioned in press conferences delivered at the White House. And what this model does is it predicts how many people are going to die each day of the epidemic. And like, well, how does it do that? And there are a lot of different ways of doing it. The way this model does is it says, all right, well, there are other cities that have gone through this already. So take Wuhan, China. They've gone through it already. And we know when they implemented social distancing measures, and we know what happened after that. And so we can make predictions. We can sort of, in a sense, paste their experience onto whatever city we're looking at. So in this example, New York City. And you make certain adjustments, of course, because they're not exactly the same. And what you see in this graph along the horizontal axis is the date, and the vertical axis is the number of deaths per day. The solid red line, well, that is what we've already observed. And the dashed red line, that's our prediction going forward. And you adjust it based on, what you observe. So that's what you start with. Now, of course, that's not what we're directly interested in. For this project, we're interested in hospitalizations. All right, so the model also predicts hospitalizations. Well, how does it do that? Well, it does start with deaths, as I said. And so there's the deaths graph again. And what it basically does is it says, all right, hey, if we predict there's going to be 10 deaths today, that means we can make a reasonable inference that last week there were 100 people with COVID in the hospital. And I'm totally making this up, but you get the idea. And you can have like a computer model that, translates what happens when you've got 100 people in the hospital. How many deaths is that going to turn into in the following week? And so that's how you get from, okay, we've taken the Wuhan experience, we've kind of adjusted it a bit to fit New York, and now we're gonna like walk backwards and make a reasonable assessment of what we think is going to have happened in the hospital. So now we've got a model of what is happening in the hospital. So that's great. The problem is that when we looked at the predictions that the IHME model was giving us, they were way off. They were like a factor of 2 or 3 too high compared to what we were actually observing in Boston at that time. So we said to ourselves, like, all right, look, the IHME model, it's telling us something. It's sort of telling us when the peak is coming up for this epidemic, but the magnitude is off. The height of the mountain, the shape of the mountain is right, but the height of the mountain is way off. So we're going to do our own modeling. So what we did is we said, well, let's take a look at hospital admissions for the state of Massachusetts. And fortunately, the Department of Public Health puts out that information. And here you've got it, for the dates ranging from March 29th through April 13th. That's what you see along the horizontal axis. And then on the vertical axis, that's the number of people who went into the hospital, according to the Department of Public Health, somewhere in the state of Massachusetts each day during that time period. And here's the challenge. All right, what's going to happen next? Here's the data. Predict what the next red bar is going to look like. And quite frankly, that's a hard thing to do because these red bars are jumping all over the place. And so it's sort of hard to see a pattern or use statistics to figure out what's going to happen next. So, one thing I started thinking, I was like, well, look, the incremental number of people going to the hospital each day, those red bars, that's jumpy. But maybe if we look at the cumulative number, so you take the first red bar, add it to the second red bar, add it to the third red bar, maybe that's smoother and we'll be able to see a pattern. Well, this is what you get. All right, now these are the same red bars, but I've increased the range of values on the vertical axis, so the red bars are much smaller, but there they are. And the blue line that you see in this graph, well, that's the cumulative number of hospital admissions for each day, again, going back to March 29th and extending all the way out to April 13th. All right, well, that's very nice. And you could imagine extending that line by just taking a ruler and keep going up. But what that doesn't tell us is is there something subtle we're missing here, where the blue line is beginning to bend down maybe and hopefully turning so that, it's no longer increasing as fast. And you can sort of see a hint of that in the far upper right-hand corner. It seems to be bending a little bit. But again, it's very hard to make a prediction off that. So, I was having a hard time figuring out what I was going to do next to make predictions of when this curve was going to bend. And I was taking a walk in my neighborhood, which I like to do because I like to average 10,000 steps a day. And I came upon one of my neighbors who I hadn't seen for a while. And we had a conversation. We were 25 feet apart, but we had a conversation. And his name's Bruce. And Bruce asked me, hey, what are you up to? And I told him what I was working on. And he said, you have to talk to my good friend, Jack Pryor, who it happens to be head of manufacturing science at Sanofi. And he's at home now. He went to MIT. He's a really smart guy, really good at math. And he's been working on this COVID-19 problem. He's got some ideas about how to model the epidemic. And I was like, wow, that's pretty neat. So I got in touch with him over email. And what Jack said to me is, he said, look, what you have to think about is what's happening to the growth rate. And I'm like, the growth rate? What's the growth rate? Well, here's the growth rate. I'm going to show you what the growth rate is. All right, let's take March 31st. And on this graph, you just see I popped up the number 100 over 331 there. That's the number of new admissions on that date, roughly 100 people. And what was the cumulative at that point? Well, going into that day, we had like 550 people, let's say, who had at some point up to that date come into the hospital with COVID-19. So the growth rate is just the number of people, new people we get on a given day, divided by the number that we've had all the way up to that day. So in this example, it would be just 100 divided by 550, or 18%. So that's the growth rate. And what Jack said to me, he said, if you look at this, there's a certain pattern to growth rates, whether you're looking at new cases of COVID-19 or you're looking at fatalities. And I said, well, why don't we look at hospitalizations? He said, well, that's an interesting idea. So that's what we did. And here's what we got. So this is the same graph, but now you see these dots, all right? And those dots are the growth rate. Now, hang on a second here, because the growth rate is being plotted on the vertical axis on the right. So I've just put a red rectangle around it. So there it is. And so the growth rate, and it's not 18%, it's generally smaller than that. And one thing I want to point out about this vertical axis is it's scaled in a funny way. You would think normally you would go 0%, 10%, 20%, 30%. This axis doesn't go up by additive equal increments, 10, 20, 30, 40. It goes up by multiplicative increments that are the same. So it starts out at 1% at the very bottom. You multiply that by 10, you get up to 10%. You multiply that by 10 again, you get up to 100%. And those are the numbers that you see on that axis. And what Jack said is, if you plot the growth rate over time on this kind of, it's called a log transformed axis, this multiplicative axis, they kind of fall on a straight line. Now, there's a funny thing here, and this is why the dots are different colored. These dots, the purple dots, those are kind of the weekend dots, which are Saturday, Sunday, Monday, and there's kind of a reporting lag, we think is what's going on. So those dots tend to be lower than the green dots, which are the weekday dots. So you kind of have to keep them separate. That's, you don't want that distortion. But basically, if you set that aside, the dots that represent the growth rate fall on a straight line that is declining. So we say that on a log plot like this, the growth rate falls at a linear pace. Now, that's a fancy math, but here's the important point. You can actually predict what the growth rate is going to be over time. Again, we're taking a ruler and we're doing an extrapolation. It's not like there's some, underlying biology that we understand here, but if you believe in the extrapolation, it gives you some insight here. So this is Jack's computation And he fit the blue line to the blue dots. Those are the weekday dots. And he came up with a formula. All right, the formula's got some math in it, but here's the important thing. The important thing is that if you put the day number into the formula on the right, and the day number is just the number of days since March 24th, and Jack chose March 24th because that's roughly when we started doing social distancing in Massachusetts, then you can get a growth rate out on the left side of the equation. And, you can put this into Excel and it works, and the algebra is a lot of details to the algebra, but it works. And what this formula says is, you'll see just to the left of that day variable on the right side, there's that negative 0.07. What that means is that each day, the growth rate falls by 7%. That's the negative 0.07. So if it was 10% on one day, the next day it would be 9.3%, because 9.3% is 0.93 times 10%, or 7% smaller than 10%. Again, a lot of tedious algebra there, but the point is you can predict what the next value is going to be. All right, great. So what do we do with that? All right, good. We can predict the growth rate. How does that make Mike Apcon, the head of Tufts Medical Center, how does that make his life any easier? Well, let me show you how this becomes relevant. All right, so this is just an illustration, but we've got days since March 24th right here, and we've got our formula for predicting what the growth rate is going to be. So if we plug those day numbers into this formula, we get some growth rate. So you see it starts out at 9.5%, and then 8.8% is the next value. That's 7% smaller than 9.5%, and so on. And then what we can do is we can say, all right, we know how many cumulative hospital admissions there have been in Massachusetts up to this date, because this is past history. 2,385. All right, let's just pretend that this is today. We want to predict the values going forward. Well, if we take 9.5% and we multiply it by 2,385, because this is the growth rate, apply the growth rate to the cumulative number so far, well, we're going to end up with 225 new admissions. That's a prediction now. That's something that we can predict from our formula without actually observing it. Then what you can do is you can say, look, we can take that 2,385, add 225 to it, and what do we get? We get a prediction for what the cumulative is going to be tomorrow. Well, now tomorrow we know that the growth rate is 8.8, or we predict it's 8.8%. We can apply that to 2,000. We can multiply 2,610 by 8.8%. That's going to give us the 231 in that far right column. And we can keep doing that over and over and over. And what we get is something that looks like this. So again, along the horizontal axis, we've got the dates. Those blue dots are actual observations, all right? Those are new hospitalizations. The vertical axis, notice that that's that multiplicative type of scaling. It goes 1, 10, 100, 1,000. And the dashed blue line, that is what we predict hospital admissions to be. And so you can see these blue dots go through April 13th. We're very excited. We're like, great, we've got something now. We can see whether our model works. We'll keep plotting the blue dots. We'll see what happens. And on whether, I think it was April 13th or April 14th, the state stopped publishing hospital admissions. And like, this is terrible. Like, come on, guys, please keep publishing this because we want to keep doing it. And I guess, they felt those numbers weren't very reliable. And so they were going to publish different kinds of numbers which weren't as useful to us. And we were very disappointed. But a week later, this is what happened. I kid you not. A week later, they come up with a new type of document that they call the state's COVID-19 dashboard. And on page 14, they've got a pie chart that has the cumulative number of hospitalizations, and it's broken down by race, and including people for whom they don't have the race identified. So for the purpose of this graph, we're interested in new hospitalizations per day. Now they're telling us the number of hospitalizations that have cumulatively occurred on each date. So if we just take the difference from Monday to Tuesday, that gives us the number we want. And so as of this week, so this is where they stopped. So we've started getting our dots back. Now, so, and the good news is it doesn't look too bad, right? Those blue dots, they kind of fit within the uncertainty band. That's the red dashed lines for our prediction. But the question is, all right, do you believe that the hospitalization numbers, are they going to decline as our prediction suggests, or are those blue dots going to continue going out to the right? And that, of course, is the big question. And, this is the problem with, trying to predict what's going on before you know how the story is really going to come out. We don't know, but we can actually look at some other pieces of evidence that help us out. Now, I showed you how we predicted hospitalizations. You can, as I mentioned earlier, you can do the same thing with cases and with fatalities. So I'm not going to go through the details here, but this here is the prediction for growth rates for new cases. And here, the big takeaway is that the growth rate should be declining by about 5% per day. And there are a bunch of predictions that go along with that. But now we can also look at the fatality growth rate. And the fatality growth rate, if you do the same sort of exercise and you plot those dots on that log transformed axis, you find out that the fatality growth rate should be declining at about 4.2% per day. Now that's a slower decline, all right? So that's one thing to notice. 5% rate of decline for the growth rate for cases, only a 4% per day decline in the rate in the growth rate for fatalities. So now that has some interesting implications, by the way, which I'm going to just talk about for a moment before I return to what this can help us understand about hospitalizations. So here is a graph that has on the horizontal axis time, and on the vertical axis it has this thing called the case fatality rate. Now what's the case fatality rate? Case fatality rate is just the number of fatalities divided by the number of cases. It is, unfortunately, it's the fraction of cases where people end up dying. And obviously you want that number to be low, but what this graph is predicting is that that number is going to increase over time. Now what's going on here? What's going on here is, remember, we said that the rate of growth for fatalities was going to decline at 4.2%. So yeah, fatalities are going to eventually get smaller. But cases, they're going to get smaller at a faster rate. So the number in the numerator, the top of the fraction, is getting smaller more slowly than the number in the denominator, the bottom of the fraction. And when that happens, the size of the fraction overall gets bigger. And so that's what this kind of computation suggests. Now, it's not that the virus is becoming more deadly, right? So what's going on here? How can this possibly be? How can the case fatality rate increase if the virus is not becoming more deadly? Well, we've got a couple ideas of what might be going on here. One idea, and this is Jack's idea, he said, look, we're not increasing the amount of testing we're doing, really. We've sort of tapped out all the lab testing that we can use in the state of Massachusetts right now. So over time, we're basically not going to discover more cases of COVID-19 each day. We just can't, because we can't test more than we're currently testing. If more people are sick, unfortunately, they're not going to get tested. Now, hopefully that all changes, and eventually it will. But as you can see from this graph, it has not done so yet. On the other hand, of course, deaths, those happen. You don't need a test to detect those. So the number of deaths is going to increase over time if more and more people get sick, but we won't be discovering more and more people getting sick. So the fraction, if you take the fraction, the number of fatalities, which is growing, and you divide it by the number of cases, which is not growing as fast, well, it's going to look like the fatality rate is increasing. All right, so that's one idea. Second idea is that we're not really looking at two different populations here. I'm sorry, we are looking at two different populations here. Fatalities and cases are not really the same people. And here's what I'm talking about here. And it's, it's one of the tragic aspects of this disease. So here is, we're looking at cases in Massachusetts since the outbreak started. About 18%, 1 in 6 cases, is someone who is connected with, usually a resident, of a long-term care facility. That's bad enough, all right? But take a look at fatalities, and this is shocking if you're not already aware of this statistic. Over half of the fatalities are from long-term care facilities. So that's, of course, tragic, but it also has implications for what's going on when we're trying to figure out case fatality rates. Because really, when we're looking at case fatality rates right now, we're really getting dominated. When we're looking at the fatalities, we're getting dominated by the experience in these long-term care facilities. When we're looking at cases, that's the general population. So it's two different groups, and different things can be happening in terms of how the disease is evolving in those groups. And so you could have a change in the case fatality rate because you're matching up numbers from two different groups. They don't really belong together. All right, what I'm going to finish with here, this is my last substantive slide. You've almost survived me. Remember, our original question is what's going to happen with hospitalizations in Massachusetts? And so, we've got these limitations with the data. We want to know what's happening, what's going to happen next. So, we can tell ourselves a story. We can say, look, maybe we can learn something, because hospitalization for COVID-19 does not happen in a vacuum. You've got hospitalization, and sure, before that, you've got cases, right? So if someone's hospitalized, generally, before that, they will have been diagnosed as a case. And after that, some of those people, unfortunately, are going to be fatalities to the disease. And what do we have in terms of our statistics? This is a stream, it's a pipeline. And you would think that in terms of the growth of cases and the growth of hospitalizations and the growth of fatalities, they have to move in parallel at some level, right? You can't have fatalities growing forever if hospitalizations are shrinking. So hospitalizations, we said the growth rate for that is declining at 6% per day. For cases, remember, the growth rate for cases is declining at about 5% per day. And for fatalities, the growth rate is declining at about 4% per day. And so what has to happen here is at some point these have to come together. And, if hopefully things are going to converge more towards hospitalizations, and there is hope for that, because hospitalizations, that's a hard number. We observe those. It's not subject to, how many tests did we do today and who got tested and all that. It's what statisticians like to call a hard statistic. It's something that's, when you observe it, it's more reliable. And hopefully that will, in a few weeks, translate into fewer fatalities. Of course, things might go the other way, but the point is that, we are trying to piece together this fragmentary information with these stories about what is happening in the disease to try to understand what will be happening tomorrow, next week, and so on. And with that, I will end. And guess what? I think I actually came in without talking too much over my allotted time.
So Josh, first of all, thank you so much for this presentation and for the work you're doing to help us figure out how to respond to the epidemic. And I think you touched on it in your talk, but at all the community stakeholder engagement groups are really interested in issues of health equity. And you talked about the difference between the overall population and the people who are tested and the people who die. Can you talk a little more about any equity considerations that go into what we're seeing in Massachusetts?
Yeah, I mean, it's an excellent question, and sadly, of course, equity this is not an equal opportunity disease, and so some groups are being hit particularly hard. That by itself is a concern, but even from kind of the cold perspective of wanting to plan for what is happening, it is ultra crucial that testing be done in all communities so that we understand what's going on. Because if we just do testing, or if we don't do enough testing in those communities that are hit hard, well, what's going to happen? Those people are eventually going to end up in the hospital, and we will not know that they are headed that way, and we won't be able to plan, and that will be worse for everybody. And sadly, what the epidemiologists are telling us is, we get this first wave under control, we're going to be dealing with subsequent waves, and it's going to be really important, they say, to monitor what's going on so that we know when we're going to get hit again, and we know when there's a problem. And so it's going to be just as important for everybody. I mean, even if you were the most selfish person in the world, it's going to be really important to understand what's happening in every single community, because otherwise it's going to be bad for everybody.
Thanks, Josh. Maggie, do you want to ask the next question?
Sure. I think there's been some general inquiries about whether we can share this recording. I believe we can. I'll make sure that we can get that posted somewhere or share it around. I think there were the first question we got was from Chelsea St. John. Don't know if this could be answered or not, but people who recover from COVID-19, are they more likely to catch a different strain? If so, do symptoms differ?
I as I said, I'm not a medical doctor, so I mean, I just am not in a position to answer that kind of question.
Okay. And Josh, there were a lot of questions about the accuracy of testing and how sensitive tests are, how specific they are, and how that affects the models.
Yeah, so I don't know the details. I do know, we've all heard that there's, these tests are far from perfect. That, I mean, the number that I recall hearing from press information, although, it's already, a couple weeks old, and these days, a couple weeks, a lot of things can change because the technology is changing so quickly. But that the sensitivity is not 100%. The number I heard, and I don't know if this still applies, is that the sensitivity might be like 70%. But these numbers are changing all the time as the technology is changing. And I believe, talking to some of the clinicians I've been working with, when someone comes into the hospital, even if they test negative, if it looks like COVID, clinically, these people are treated as if they have COVID, because the reality is, especially this time of the year when the flu has subsided, there's a good chance that they really do have COVID.
Maggie?
Okay, so there was another question about whether these predictions take into consideration social distancing and how to what extent that can be measured. And then there was also a comment that was sort of related, that some groups have used GPS data to assess adherence to social distancing.
Yeah, so that's actually a really interesting question, because, and I didn't get into it, but there's sort of two approaches to modeling. And one approach would be to say, all right, well, look, we understand that the way this virus works is, it gets into people, And for each person who gets infected, on average, they infect another 2 or 3 people. And, so we can map out what happens. One person turns into 3 people, turns into 9 people, turns into 27 people, and so on. And social distancing, well, that, cuts down the efficiency of spread by, let's say it cuts it down by 1/3. Well, that would mean that instead of going from 1 to 3 to 9, it would go from 1 to 4 to 8, because the number of people infected by each existing infected person would be 2, and so on. And the problem with that, or I should say the challenge, because all these approaches have problems or challenges. The challenge with that is that we cannot observe what that reproductive constant is. That 2, is it 2, is it 3, is it whatever? And it's probably really different in different populations. It's going to depend on, what is someone's activity, what are their living arrangements, on and on. How do they get to, if they're still working, how do they get to work? Those are really tough things to observe. So in our experience, what we found was that those kinds of models were so uncertain that we really couldn't use them. So instead, the other kind of model that one can use is the kind I described, which says, we're not going to pretend to understand what's going on with the virus. We're just going to fit curves. Now, the upside of that is you're looking out the window to figure out what's going on. And so you're tied to reality that way. The downside is that you're not building into the model the fundamentals of what might really be going on. And so your ruler might predict something that is just completely unrealistic, because something might change that you're unaware of. So, there are trade-offs between these different approaches. But the short answer to the question is, implicitly, what we have done takes into account social distancing, because we're just fitting a curve to the data that we're observing, which reflects implicitly social distancing. But we don't really understand what's going on, so we can make mistakes in terms of extrapolation.
Josh, that's really helpful. There's another question that came from David Cherboga, and I just want to bring that up with some other questions that came along. The number that you have, it's called hospitalizations. Those are people who are newly hospitalized today. Is that correct?
Yeah,
so,
that's correct.
So when you work with the hospital and they have to plan resources, they also think about how long someone's going to stay in the hospital, and if they change the criteria for who gets hospitalized and when you send someone home, does that matter? And what does the hospital need from you from doing all this modeling?
Yeah, so the answer is that so the second part of the modeling exercise that I said I wasn't going to talk about, that is exactly what you're talking about. And it's a big part of the exercise. And I could talk for an hour about that. And so this model does take into account exactly those considerations. How long does the person on average stay in the general ward? What fraction of them proceed to the ICU? Once they're in the ICU, how long do they stay there? How long are they going to be on a vent? And so that's not information that we control, of course. It's not, we don't tell the hospital, hey, you got to take people off the, get them out of the ICU. We just tell them, look, this is the implication. We observe this distribution for how much time people are spending in the ICU. And the implication is you're going to have a lot of people in the ICU, and it may be more beds than you actually have. So think about that and maybe line up, figure out what is the overflow hospital going to be. That's the sort of control measure or management step maybe that the leadership of the hospital wants to know about before it actually happens, so that they can have time to identify solutions for these kinds of problems. I don't know if I didn't completely answer the question. Tell me.
No, I think you did a good job, and I think that what we're seeing in the hospitals in our state is they're relying on models like that. Because I know that I'm a pediatrician, and they closed the pediatric ICU and moved all the patients somewhere else, so they had more intensive care unit beds available for adults, and it was terrific because you can't just move them, say, sorry, someone else needs your bed right now. They were able to prepare another space for the children, get them all moved, and then of course your model was correct, and all those bed spaces were needed for adults. But it's very interesting to see how hospitals depend on that. And in subsequent meetings, we're going to hear from other health systems, and I'm sure that they have modelers like you who are helping them figure out how many more ICU beds they're going to need, and maybe convert a post anesthesia unit from where they're not doing so many surgeries to become a new ICU, or whatever. And I just want to say I think that it's pretty much time for us to wrap up. What I'd like to do is say that we're going to figure out how to post this and the chat box on our CTSI website, and we'll send a note out to the leads at all 4 CTSIs in Eastern Massachusetts. And Josh, before we go to the closing remarks, do you have anything that you'd like to say about what this has meant for you as a researcher, and how your contribution in all this, and what's happening in your life, or anything else you want to talk about for just
Yeah,
a
I mean,
minute?
listen, I'm sure it's true for a lot of people. Your regular job gets kind of put on ice, or at least doesn't. At least to me, my regular job doesn't seem quite as important. And because I just want to be able to do something, and I'm not a medical expert. My sister's a nurse, so she gets to be useful, and this is not as useful as she's being, but I'm glad I can put my knowledge to some sort of use, and being able to work with great people on it, it has been rewarding in that way.
Great. I really appreciate it. And it's not as direct as what your sister does, but I'm sure the planning that you and the other people at the other hospitals have been able to do has saved many, many lives, because people are finding that when they get ill, in fact, we have the resources we need, which was not, which didn't necessarily have to happen. It took a lot of thought. So what I want to do, though, is just prepare you a little teaser for our next session next week, also on Thursday at 4 p.m. This one will be sponsored by the University of Massachusetts, their Center for Clinical and Translational Science, and the speaker will be Anastasia Kavorova, and she's going to talk about RNA therapeutics, informational drugs as a pandemic response tool. And this is really interesting because we are all really depending on our scientists to develop new tools to understand and treat the effects of COVID. And without better treatments, we're facing a fairly bleak future. I know that all 4 CTSIs are involved in clinical research around novel ways to treat this novel virus. I know I'm looking forward to next week's talk. There will be 2 more talks in this series, and depending on the response, our CTSIs have indicated we're willing to keep going and keep producing these. But we would like to hear from you about what you liked, what you didn't, any future topics you have. And I want to thank you for your attention, and thank Josh again for the work you're doing. And Josh, you're one representative of many, many investigators who have put their regular work aside to help deal with this epidemic. We're very fortunate to have you and to have the other investigators at Tufts and throughout New England working on this case. But boy, do we
Thanks
need
for
it.
having me today.
And if anyone has questions or comments, you can please send them to either Maggie Fenwood, mfenwood@tuftsmedicalcenter.org, or to me, rsegi@tuftsmedicalcenter.org, and we'll be happy to respond to you and to develop this. And one more shout out to our partners at the Harvard, UMass, and Boston University CTSIs for all the work that we did behind the scenes to make this happen. Thank you so much. And I wish everyone good health for you and your families. And I look forward to the day when we all get to be together physically again someday, safely.